On today's work, we are going to talk about neuroimaging in post-traumatic stress disorder. Before start talking about the neuroimaging applied to PTSD, we would like to introduce this disorder. It is considered one of the subtypes of anxiety disorders, and it can develop in individuals that were exposed to one event or multiple events that involve the threat of death or serious injury. And those people reacted to these events with intense fear, helplessness, or horror. This disorder develops in 2% of the people that are exposed to any types of accidents. And of all psychiatric disorders, PTSD poses one of the greatest challenges in healthcare since it is very complex and it varies a lot the signs and symptoms of the patients. Now, regarding the clinical presentation of PTSD patients, these patients re experience the traumatic events they have passed through in the form of nightmares, intrusive thoughts, flashbacks, and physiological arousal in response to the trauma. These patients might attempt to avoid the reminder of the trauma and may experience a restricted range of effects, especially the positive ones. And they also experience hyperarousal symptoms such as hypervigilance, exaggerated startle, and difficulty sleeping and or concentration. In a typical case of PTSD patient, this patient will persistently avoid either trauma related thoughts and emotions or any conversation regarding this matter. And they may even have some one type of amnesia that it's called the dissociative amnesia. This clinical presentation it usually occurs 3 months after the traumatic event. Regarding the diagnostic criteria, we present here the two classifications, the DSM-5 and the ICD-11 for PTSD, and they are very similar and they have a lot of descriptions that we already discussed. So the exposure to this threat of death or serious injury, these intrusive thoughts, avoidant changes in cognitive and cognition and mood, arousal and hyperactivity. I'm more focusing on the DSM-5. The duration, it's usually more than 1 month of these symptoms, clinical significant to impair some of the area functions of the patient, and it's due to the event and not physiological effects or substance or medical condition that need to be ruled out. Regarding the neurobiology, we have the information that there are some structures that are involved in the PTSD, such as the amygdala, the medial prefrontal cortex, and the hippocampus. In the case, the amygdala it's hyper responsive to the traumatic events, and that's why we have an exaggerated fear response. And there is also the ventromedial prefrontal cortex that it's going to be hyper responsive, and that's why it's going to fail inhibiting the amygdala. Also, there are some neuroimaging studies that confirm that there is an hippocampal volume decrease. Besides this, we also have an altered cortisol receptor sensitivity because in the stress response, the HPA axis will be activated in the acute phase. Um, and in PTSD patients, we have the report that there is a significantly lower ACTH response to the CRH released by the hypothalamus compared to normal people, that it's called the blended ACTH response. And finally, although they have a lower cortisol levels compared with normal people, in acute stresses, we can have some spikes in cortisol that will have a neurotoxic effect over the time. Now, regarding indications, we have, for example, the research purposes to try to investigate the underlying structures and functions that are involved in PTSD. Also, we could try to identify some biomarkers to have the information of the onset, severity, and possible treatments of the disorder. Try to explore different treatments and how they could affect the brain structure and function of these patients. And about the clinical purposes, try to rule out other disease or other disorders, and try to establish a differential diagnosis and assess comorbidity conditions that could conditioning and complicate PTSD diagnosis. Finally, pre and post treatment evaluation to try to establish a baseline before the treatment and monitor changes over the course of the treatment. Each imaging technique has its advantages and disadvantages. Regarding the functional MRI, it has the advantage of high spatial resolution, being non invasive, and no radiation, but it's very expensive and not accessible, and it measures indirect biomarkers rather than the direct ones. The SPECT, it's more accessible, simpler methodology and less expensive, but it has a lower spatial resolution that decreases the accuracy, and it has the radiation. And finally, the PET, it has the advantage of measure the direct glucose metabolism, and has a high sensitivity for functional changes in the brain. But it uses radiation in high quantities, and it's more expensive and less available.
We will now present three tables that show the differences in the findings between the different imaging techniques. So, in the MRI, we can see the decreased activity in the prefrontal cortex, the increased activity in the amygdala, altered connectivity and hippocampal dysfunction, and also the changes in the anterior cingulate cortex. In the SPECT images, we will have the same findings as the ones in the functional MRI. However, as the SPECT evaluates perfusion, we will see those images but regarding perfusion. For example, in the prefrontal cortex, we will have hypoperfusion, but in the amygdala, we will have hyperperfusion. Uh, we will have the same findings as I have said, but with the addition of the thalamic changes. In PET, as it is based on the glucose metabolism, we see a decreased glucose metabolism in the prefrontal cortex, an increased glucose metabolism in the amygdala, and also hippocampal metabolic changes, altered neurotransmitter activity, and changes in the anterior cingulate cortex, which is similar to the previous neuroimaging techniques. In this slide, we will show study findings of an article named Neuroimaging in Post-Traumatic Stress Disorders and Other Stress-Related Disorders. It was written by J. Douglas Bremner, MD, and it was published in 2007. This study concluded that PTSD was associated with cognitive deficits, particularly in the verbal declarative memory, and that these deficits have been observed across diverse backgrounds. The hippocampal volume was shown to be reduced. It was also seen that a medial prefrontal cortex dysfunction and an increased activity in the amygdala, all of which have been also seen in the neuroimaging techniques that I have previously mentioned. Regarding memory impairments in PTSD, it was seen the verbal memory impairments. However, visual memory and the IQ generally remain unaffected. These images show the changes in the hippocampal volume on MRI in PTSD. On the right, we have an MRI image of a patient with PTSD, and we see the smaller hippocampal volume. In comparison, we have on the left a non PTSD subject, which is normal. The images in this slide and the ones from the previous one and the next one are all taken from the article that I have already mentioned. The pictures in this specific slide are SPECT scans. They were taken from combat individuals, some with PTSD and some without PTSD, and they were taken while these combat individuals were exposed to traumatic combat related slides and sounds. And so, going over the scans, we can see that number 5 and 6 have a higher overall activity, while the 7 and 8 have a lower activity. And we also know that specifically in the medial prefrontal cortex, there is a dysfunction in the PTSD, which we can see in the number 7 and 8. So we can presume that those are the ones that belong to the PTSD individuals. These images, also from the article, are PET scans and they were taken from women with abuse related PTSD. The yellow areas in the amygdala show the increased activity during the acquisition of conditioned fear learning. I hope you have enjoyed our presentation. Thank you.